mic है कोई? No, he's giving you a mic. Or you come
You
there
got
and
a
speak.
loud voice.
No, you come and speak in the mic there, but better. Yeah, please come in.
Hi, namaste everyone. I'm Shruti Dave. It's the first time I'm actually coming to AIOC, kindly invited by Dr. Sethis, and it's been wonderful. So I'm an ophthalmologist in South Africa, in Port Elizabeth, and I'm in private practice at the moment. I've been in government for many years, and I still do a lot of volunteer work with our local state facility. Yeah, we do a lot of cataract outreach, so I think this is very pertinent to what we're going to listen to. Thanks so much for the invitation. It's been really
Mr.
wonderful.
Afroz,
Welcome.
next please.
Yeah.
So everybody here has been to South Africa, except Aditya.
You dropped out at the last
Yeah, he
minute.
dropped out at the last minute.
Hi, good morning. Thank you so much for your kind invitation. It's my first time also in AIOC. It's been fantastic. Very eye-opening, I must say. Very high-powered lectures. We only wish we could have all of this back home.
We'll send them across, you invite us.
No problem. I'm also in private practice, but I'm in Durban, South Africa. And I would love to attend next year. Where is it, by the way?
Delhi.
Next year, Delhi.
Delhi.
Yes.
It's along with the APAO, International.
Is it both happening at the same time?
Yes.
Yeah, we're together. It's a joint
Wow.
conference.
Okay. Thank you so much.
You're welcome. Welcome.
So we'll start today's session. Please come in the front till more people join
So
in.
we'll have our first speaker,
Where's your third friend? She's coming? Give her a message.
Dr. Arun Sethi is going to be introducing us to reaching the unreached concept of Arunodaya. So over to him.
So, reaching the unreached. As you know, in the developing world, it's very important that we should be able to cover all sections of our society, including those who may not be able to afford cutting-edge ophthalmic surgery. Forward कैसे करेंगे इसको? So basically, when we started our practice in 1990, we formed a trust called Arunodaya Charitable Trust. The word Arunodaya comes from Sanskrit and means the first rays of the sun. And we founded a small organization. We saw our first patient under a tree, and from there we grew to now cover 1.6 million patients. Now about our organization, as you can see, the objectives are to reverse the tide of avoidable blindness, increase eye care awareness, especially in the lower sections of our society, knowledge and skin transfer amongst friends of ACT, and provide comprehensive eye care to the community. So this is how we run the program. We have a base hospital, and then we have a village outreach program, we have a school screening program, we have a mobile ophthalmic unit, and we have satellite centers in Delhi at Mataka Mandir, and we had one before this in Jharsa. So you can see that the base hospital is linked to all four of them. So basic services are given in the peripheral centers, and as mentioned in the slide, and those which we do not give in the peripheral centers are then transmitted to the base hospital. Now during the pre-COVID period, that's very important because COVID changed a lot of things. In the pre-COVID period, we used to have a village outreach program. You can see some of our patients are waiting there for the team to arrive for the screening because we would advertise a couple of days or a week before that a team will be coming. And what we tried to do was awareness building, patient sensitization. Then we used to have campaigning to make awareness, training of local volunteers, conducting comprehensive eye care camps, providing free glasses and eye medicines where required, and referrals for investigations like OCT and surgery were required. So we also gave a healthcare and eye care education to them. Now, you take the case of visual acuity, refraction, a detailed eye examination. Now we even carry a portable slit lamp and a portable non-contact tonometer with us, and then giving them counseling for glasses. So you can see how many villages have been covered in the district. This is a Google map that was created by Dr. Aditya. Then we had the Netra Jyoti Abhiyan. Now this is a program that was started with the idea of taking our vans into the villages, providing services in the van because we had places where we did not even find a roof to be able to hold a camp, and bringing patients back for surgery to a hospital, which you can see in the background. So this is how the vans were equipped. They had an ophthalmic chair, equipment, and we were using them. So you can see how Dr. Weber was there examining a patient. Dr. Aditya used to chip in if there was a shortage of optometrists. and we would all help out to do it. Please come forward. So we also did a very interesting program called the School Screening Program. And we are happy to say that this has also been copied by the South African Society for Prevention of Blindness. Mr. Kruger had come down here, and we have a long link with you. In 1992, we had gone to South Africa for the first time, where we met Dr. Koenig, Harold Koenig, at the Pretoria Institute at Schumann Street in Pretoria. And then he came and conducted a workshop at the AIOC in 1994, where he taught phaco at our hospital to doctors who were just learning phaco. He is now retired in UK. And his colleagues used to be Jan Talma and others that way. So this project is called They See, They Learn. It's based on training of teachers. And the teachers are trained through an e-chart, which I think a sample is with Dr. Aditya. And through that e-chart, you'll see at our hospital, we would train the teachers, and then they would check the eyes of the students. So if there are 2,000 children in a school, you normally expect around 20% to have a refractive error, and that will save a lot of our time and effort in doing that. Then we used to conduct pediatric eye care camps. Then all students who we saw there, because the government regulations could not have a cyclopedic retinoscopy, till we referred them to the hospital. So we would do a dry refraction where the prescription was more than 0.5 spherical, myopic or hypermetropic. Only then we were giving them glasses. Otherwise recommending that they go to the local government centers and have a checkup done. And then of course we also had a program of giving them education through an e-chart. Even do now also in the hospital we'll show you, whereby you go home as a patient and check the eyes of the surrounding people, because they already have an entry into the community. So for a new foreign body to go into the community takes a long time, but if you use local community services, you'll find, like politicians, you get a better result. So this is how we do the retinoscopies, the autorefractometries, and eye examination by our doctors. And the school screening program was held in the rural schools mostly, and in the government schools. And we covered around 60,000, Dr. Aditya? 60,000 children were covered out of that, and I think we show you the figures also. That's the one. So schools covered 124, children that were screened was 60,740. We gave away 6,890 pairs of glasses with support from SABIC, and 1,943 children were referred to for further treatment. So we run satellite clinics. We run 2 of them. These centers are aimed to identify and screen patients who can't base access to the base hospital. So they give referrals for surgery. Yesterday, Thursday, I was there at the referral clinic because the boys were here, and we had 47 patients and about 4 cataracts and 2 patients with diabetic retinopathy. So you can catch them at the doorstep. So you see that's a reception of the Mataka Mandir clinic where I was telling you I was a Thursday afternoon, and people seeing the patient during COVID, Dr. Aditya examining a patient there. These are the primary health centers in Gurgaon where you're coming today in the evening, and where we network with the primary health centers. And so we have about 12 of them. These are places where the poor people or the local villagers go for cold, cough, and we give the eye care services. So in the post-COVID area, we developed a vision center with support, and you can see that the vision center was catering to patients. Unfortunately, we couldn't run it for very long because we lost the funding for it after a year. And this is the hospital. It's called the Arunodaya Deseret. Aruna, as I told you, is the first rays of the sun. The word Deseret comes from the Book of the Mormons in the United States of Utah, and it means a beehive. So the beehive concept, all bees work in a limited space to produce something sweet called honey. So they have projects all over the Middle East, Africa, and developing countries to do that. So with this, we'd like to show you some of our hospital, the ground floor. So this is the page section, and you can see it's neat, clean, and looked after. There's the optical shop, and you can see the examination centers, the equipment, and then we have the super specialty wing, which is recently added. So there's Dr. Weber, Vitreoretina, there's pediatric ophthalmology by Dr. Aditya, and there is glaucoma services by Dr. Saiban, who will be joining us shortly. And then we have the clinics here. That's a retina clinic. And we have diagnostics area. That's where our scrub stations are, OT theaters. And then we have the basement. So even a charitable wing, it's very important, even if you do free work, it should be clean, hygienic, and attractive to the patient. They should get quality eye care, otherwise they will not come. So that's Mitt Romney. He's the work, Deseret, comes from Utah, and he's on the board of Charity Vision, with which we are collaborating. So he ran for the US presidential elections and lost to President Obama, and now is a senator. So all the list of organizations that have worked with us since 1990. And you can see Dr. Bill Jackson, yesterday was his 89th birthday. So next year we invited him for his cataract surgery on the 90th by Dr. Reena from the US. So we get a lot of international volunteers who work with us. So this will give you an idea of what we have been able to do till now. We are nearly touching 673,119 surgeries and 95,672 spectacles. So when you add up, it means a lot, but it also means a lot of effort because as you know, community work takes double the effort than normal work does. So our motto is that the only thing worse than being blind is having sight but no vision. Most of our doctors spend all the time doing private practice. That's also required. But if you can go a little beyond that and do something community, because that's really great. And thank you very much for a patient hearing. Dr. Reena Sethi, the director and the co-founder of the Charitable Trust, to give a presentation on how to simplify cataract surgery in medical missions. So this will be useful for the young doctors here. So before that, ma'am, can you introduce yourself because you came late? Your name and where you come from?
Oh,
You're an Afrikaner?
okay, great, welcome. You'll see a lot of South Africa mentioned in the presentation because that's where we had gone for our medical mission. So I'll just be talking about simplifying cataract surgery in medical missions. So basically, we all know that cataracts are a leading cause of blindness all over the world. And it's particularly prevalent in countries where healthcare is not sufficient to meet the load of cataracts. And the medical mission does play a very crucial role in helping out in reversing this tide of blindness. Because what happens is that we, as doctors, when medical mission comes in, you're giving technology and you're coming with a purpose. You're coming with a purpose of, operating on patients who have cataract, and then you do that. And in that way, you're also training the ophthalmologists who are in that country or that area. So before doing all that, it's very important to plan it. And in the planning, the most important part is to understand what are the local resources and what are the local needs. If you're going to start selling ice cream in Antarctica, it's not going to be a success. So we really need to know what is the requirement of that area. And the area should not be selected because we have to visit that area. Oh, I would love to, go there and enjoy a vacation, because it's not going to be a vacation any which way. So conduct the survey or questionnaire you can give to the local team and find out what exactly is the prevalence of cataract and what are the available healthcare infrastructure that is there. You need to coordinate with all the local healthcare authorities, especially the NGOs who've been working and conducting the camps and seeing that there are so many patients. So you must have an idea how many patients you're going to be treating. And you need to know what are going to be the supplies of equipment and your machines, what exactly it is. And so you prepare yourself accordingly. So is it just going to be no machines, or is it just going to be the instruments that you have to carry? Always better to carry your own instruments as well, because sometimes, you maybe you need a particular kind of a forceps or a rexis forceps, and that's not available, and it is going to bring down your efficiency levels also. And the intraocular lens support should be good. You shouldn't be wasting the time, finding out what lens is required. So basically, you need a good support system when you're doing this. And a team formation is very important. When we had gone down to South Africa, at the thing was that we went into a hospital, the J.J. Crookes Hospital, where the team had never done a cataract or any ophthalmic procedure before. So it took us about almost half a day to explain to them how the workflow and the pattern is going to be. So that is very important. And you needed a team. You needed the head nurse. You needed somebody to keep autoclaving your instruments, giving it to you, and the movement within the theater. So it's very important who all are going to function, where, what position, all that has to be worked, and all depends on the number of surgeries you're going to be doing. So you have to provide the training and the orientation to the staff available. So don't like put up your hands and say that I probably will not be able to do it, because you have to make use of what you get in the best of your ability. So also be very careful about all the cultural sensitivities, because sometimes it's just the women have to be treated in a particular way, the men have to be spoken to another way, and what are the cultural sensitivities in that area is very important to understand. And patient screening and education. So the patients have to be in the awareness campaigns have to be done, and these patients have to be given the education as to what procedure is going to happen to them and what is expected out of that procedure wise in that local community. And also who are, whenever they're doing the camps or screening clinics, the patients who are at the requirement of cataracts, especially I think you should focus on patients who are bilateral advanced cataracts or they have advanced cataracts. If there are too many patients, then give them the priority, so that at least your efforts are going to make the best to that particular patient. Patient education on procedure and post-operative care is utmost important, because you need to gather them all together and explain the pre as well as the post-operative care before you start your surgical day, because maybe by the end of the day you may not have enough time to explain to everybody. So you'll recognize this. This is in South Africa. So the first day when we went there, we had patients from the Rotary, and they were the Africans who have cataract. The second day, they were the other patients who had come from the Lions Club. And then we had the last day, there was this Satya Sai, and there were a lot of Indians who had come for the third day. They had been screened from these different camps which had already got together. So it's important to sort of see them, mark the eye, very important. The lens has to be separated out. So this kind of a duty has to be delegated to one of the technicians or helper, whoever is going to be there with you. And the surgical stepwise has to be very, you have to focus all that. You have to create a sterile operating environment. That's very important, especially if you're going into a place where they've not done ophthalmic surgery before. All the more reason that you need to set it up properly and explain the workflow to the people, and what exactly, how you want the instruments to be, rotated and autoclaved. So best always is to carry at least 6 sets of instruments per surgeon, so that you may giving it for the re-autoclaving and getting it back. That way you don't have to wait for the instruments. And if you can get 2 tables like I did, so you can just swing your microscope between the 2 and use the same machine, which was this time, I think that time it was the Alcon machine that was donated to us for that particular period. That is going to optimize your workflow and your efficiency. So just set up all that before you start. And what exact technology you're going to do. Don't try newer things on camps whenever you're doing these volunteer missions. If you're comfortable with SICS, the manual surgical technique, just do that. If you're comfortable with the phacoemulsification and you have the setup for it, just do that. Don't try new things, because that is not going to be very productive. So here's the organizing, setting up your various nurses and telling them this is your duty and this is what you have to do, and keeping everything sterile. So they already have 2 trolleys ready, and one is already there with us. So we have to see that the first thing, far most important, is the patient safety and your efficiency. These 2 things have to be very important. So just your surgical procedure should depend on that. And of course, in these high volume, if you don't have enough support, it has to be cost effective. Option cataract surgery has to be considered, because sometimes the IOLs and all that becomes a bit of a challenge. You don't get foldable lenses for all the patients, so you can always go for PMMA lenses as well. Implementing the quality and the control measures are very important. So monitor your surgical outcomes. So be very careful. So try and see the first day operated, the next day, and so on and so forth, so that you can see that your results are good. So here's my staff nurse. She was very helpful. She was very efficient once she got the hang of it. And here's Dr. Arun Sethi and Dr. Webhoff. They were doing SICS, and they had 2 tables. They had 1 table each. I had 2 tables to my this thing. And the manual small incision cataract surgery is important, because it's a low-cost surgical procedure. it's suitable for all types of cataract. Sometimes phaco, we always have a problem with very soft cataracts or very hard brunescent cataracts. So it is ideal for high volume setup like cataract surgery missions. So if you know how to do a MSI, small incision cataract surgery, I think it's a big advantage. And efficiency outcomes of similar to phacoemulsification over a longer period of time. And the post-operative care is important to be explained to the patient, monitoring the patient closely for complications. So the next post-op day, just try and see whether you have a problem or any issue, or the patient is unhappy, pain, pressures, all that have to be monitored, and explain to the patient what exactly is his goal now from onwards. And you have to address all the logistical challenges of follow-up care. So maybe you need to explain to the local ophthalmologist for follow-up cares as well, which is very important. You can't leave the patient like that after operating. Educating the patient in long-term eye health is important as well, so that they're also able to inculcate or check the eye health, like Dr. Arun was talking about the e-chart. So make them aware of eye health as well. That is also part of your mission. So here's all the patients waiting for their post-op checkups. They've been operated, and they're all waiting for that. And again, it's important, capacity building and sustainability is important. You have to train the local healthcare providers also. This is very important, because you go there and you come back, you made that effort, you need to train somebody also. So have all the local ophthalmologists, whoever want to help in, pitch in, be with you, so that you can give your tips, your way of working as well, and maybe invite them over to your area also eventually. So you need to support the infrastructure as well. So evaluation, adaptation is also important. You need to find out what exactly were your outcomes, what were your learning experience, because every time there is something to learn whenever you go in these missions. And in conclusion, an efficient cataract surgery and medical missions are essential for addressing blindness in developing countries. And medical missions play a crucial role in providing essential eye health services to the underserved communities. Encourage ongoing support for the medical missions and initiatives aimed at improving access to the eye care services worldwide. Thank you very much. So here's our team. There's a local ophthalmologist also with us, and a good successful mission was conducted. Thank you.
Thank you very much, Dr. Reena. It just shows how close South Africa is to the heart. I now request Dr. Aditya Sethi, a pediatric ophthalmologist who is involved with the pediatric vision screening in the rural schools project. He'll be telling us how you can do that. If you have any questions, we can stop, because one speaker is not there, so there's no hurry. 1, 2, 3, come in the front row. Please come forward. Yeah. Please come. So who all are flying to Delhi with us today? And Dr. Aditya will be your local guardian from tomorrow.
Slides, please. So hi, I'm Dr. Aditya Sethi. I'm a pediatric ophthalmologist at Arunodaya Charitable Trust. I'm going to talk about pediatric vision screening, rural school project. So as volunteer eye surgeons, it's very clear why we do this. Our main objective is to bring our skills, bring our knowledge to the aid of the community. So schools are a great place where community gathers. You have the future there. And if you can catch eye diseases at that age, you're automatically making an impact for the future as well as the present. So that's one of the best places to start. And this is the idea behind the They See, They Learn project, where basically we wanted to get a large number of children together in one place, screen them for eye diseases, and then make an impact by giving them the right sort of treatment or the right sort of path. And it was cost effective. It was something that made your time that you're going to spend in a particular place more valuable, and you were able to make an impact on a larger scale. So it checked all the boxes for a good community project. And like Dr. Arun and Dr. Reena emphasized, it's all about being there for people who don't have the facility or are underserved as far as the eye conditions are concerned. So that's what we did. And the importance in India is even more impactful because we have the largest number of young people in the world. We have right now crossed even China as far as population is concerned. And the good part about that population graph is that more than 60% are young. So it's something that we need to make an impact now, otherwise this will become a burden later. So the NPCB, that's the national program in India, estimates 0.8 to 1 child per 1,000 child, which is going to lose vision completely and going to go blind. So that is something we need to taper down to 0. And if we don't impact them now, it will be something which is going to be major later. The barriers we have with any other social awareness program is a lack of awareness. Often the people don't know that you're going to be there for a particular time, and that's how your time gets not utilized to the full capability for the community. But schools, the benefit is children are already reporting every day. So if you have the school authorities on board and if you have a good rapport with them, they actually bring out the notice to the community. So not only in a school screening do you actually screen children, you also end up screening adults as well, who may be their grandparents or maybe their parents or maybe the uncles and aunts. So that is something that gets encompassed in this. It's a very affordable project because you need one team who station themselves there, and the products or the consumables required are much lesser, and the equipment is fairly just a retinoscope and a good vision chart. So if you can run your program with that, you end up doing a great job altogether. Now you have to aim at population which is already underserved. You can't go to a place which is getting school screening every second week, because that may not be appreciated. And basically you need to have a standard. You need to have a protocol that you follow, and if you follow it well, you can come out with a greater impact. So this is what the They Learn project came about. It was to identify children with possible visual inability to see. That's what we wanted to do, make an impact as far as vision is concerned. Our main objective was to prevent amblyopia, because if we do not treat refractive error now, they will lose vision indefinitely via means of amblyopia. And to catch them early, because we know a lot of conditions, including pediatric glaucoma and other conditions, if caught early and treated, it's reversible. To treat other ocular morbidities, like we wanted to make sure there's no squint, there's no strabismus, there's no pediatric cataract, because if we can treat them now, we'll make a bigger impact. And refer to base hospital or refer to the nearest hospital for all the children who can come and go there. Spread health and eye-related educational awareness. I think this is the far most important point in the whole slide, because if we empower them to know what the problem is, I think 50% of the job gets done there, because parents take over. So the methodology basically was, it's a cross-sectional study. We wanted to, we took around all the underserved population of children, which basically involved government schools or NGO schools in around Gurgaon, which is a suburban district. Permissions from the authorities and the consents were taken from the parents and the guardians. Students from first grade to the 12th grade were taken, because we wanted only verbal children. Basically teachers were involved. This is Dr. Arun's pet project of teaching the teachers as ambassadors. He's actually designed a beautiful e-chart which can be printed on an A4 size platform, which was sent to the ESCRS as an innovation many years back, and it was accepted there as well. So it's a simple way of distributing a vision chart to each home, so that the child plays a game with the parent and the teacher, and they find out if they are 6, 9 or worse. So it's a simple awareness strategy which actually has reaped multiple benefits for many people socially. So all children present in the school on the day of screening were included, and schools chosen were at the 50-kilometer radius from the base hospital, so they don't find it impossible to reach us later. So registration was done for every child via the use of the teacher and the school staff, so that the child has a familiar face to attend to. A vision test was performed with the help of the optometrist. They determined basic refractive errors. They were screened into different categories between mild, moderate and severe and normal. And based on that, they were taken to the ophthalmologist. And there we had basic refraction again repeated. And there was booking of glasses. And every child got 2 free pairs of glasses. The idea was the children will play, there will be a breakdown of the glasses, and they shouldn't require us again, at least not for the next 6 months to a year. And then referrals were done in special cases, as Dr. Arun's already shown that graph of how many. So these are some pictures from the camp. You see, this is one of the nicest places to do a camp because you get smiling faces, you feel content by the end of the day. You don't feel dissatisfied. And these are some of the results. So we ended up analyzing only 18,939 students, which is one of the largest studies which is published in the Indian Journal of Ophthalmology. And we have data of close to 60,000 plus, but we haven't analyzed all of that for many reasons. So this had about 39 government schools, all between 5 to 16 years of age. And on the average, there were 946 students in each school every time we went. So you understand what is the impact of what scale we were talking about. And this is how the refractive rate error was. So some schools actually showed as much as 24.7%, which is staggeringly high. The normal, which is reported in Indian literature, is about 11.8%. And some of them were actually well served to as low as 4.2 to 3.2%. And this is something which we personally made a note of, was that the more further interior or more rural we went, the less the refractive error. So that's something we actually took note of, and we basically aimed the less use of gadgets, the less use of studies, and more of the sunlight. So refractive error prevalence in each school was also distributed as per this graph, and you can see how it's beautifully labeled between the areas. And again, most of our population was actually between 10 years to 16 years. So you can see the graph shoots up there. So less than 10 years, we had very few candidates who came to us. So it looks a little imbalanced, but that's how it is. And we are seeing young myopes come across now more often than not. That scares us a little bit because it's going to be worse as they progress. So young myopes is one of the most scary things we've noticed in our study and all over pediatric myopia studies. And age distribution of refractive error, this is how it goes. I have a lot of graphs to show, but lack of time, I'll just go through them. And we saw that the boys were affected slightly more than the girls. And astigmatism was also there. And we found a list of other ocular morbidities which were transferred to the base hospital. So basically, it's one of the largest studies done. We had 11.8% of refractive error significance, and this is the data that actually makes us want to go back and do this again. This was all pre-COVID, and we expect this graph to shoot up a little higher now. And it's very important that these activities continue, because even though it's not a profit-making activity, it's actually a very impactful activity. So great. I would like to thank your time. Thank you so much.
Thank you very much. Very well presented, very well documented. We'll move on to the next speaker. That's none other than Dr. Vaibhav Sethi, who's going to be speaking on diabetic retinopathy. How common is diabetes in South Africa? Is becoming a pandemic like India? So we need to ban sugar. And I find that most people who are diabetics tend to be very bitter about it, though it's a sweet disease, you know. So, and we would like to also accept the presence of Dr. Saiba Sethi, who has joined us. She runs on the principle of better late than never. So Dr. Vaibhav Sethi has done his residency at the Arvind Eye Hospital, and then his super specialization fellowship at Vidyaretta at the L.V. Prasad Eye Institute. And right after that, he was flown to South Africa to operate.
Yes, so diabetic retinopathy is a main problem, especially in the Indian scenario, because it has been documented in 2019 that around 77 million people are diabetic, and it's going to cross 100 million by 2030. And the national prevalence of diabetic retinopathy is around 8.9% across the age group of 20 to 79, the productive years of the age. So 1 in every 11 adults in India is affected in diabetes. And the main problem is that a high proportion of these are undiagnosed. Around 57%, that was this consensus in 2019. So amongst the diagnosed as well, around half of the patients are poorly controlled diabetics. So asymptomatic diabetic retinopathy disease is very, very common, 90 to 95%, which is a huge amount now. So because the symptoms come in when the retinopathy is advanced or when there is involvement of the central macula, and that is when the patient presents to you. And that's the main problem. So you have to actively search for it and screen for it. That's why DR screening is so important. So there are various guidelines, the All India Society guidelines, the Retina Society of India guidelines, the Queen Elizabeth Trust, and the WHO guidelines. But what they tell us is that the screening, basically the factors which promote success of the screening. Equitable screening with widespread access to laser treatment and trained staff, including administrative staff, is very, very important. Initiating and having local screening programs that are scaled up gradually is an important stepwise manner of having success in such programs. And screening offered at times and locations that meet the needs of the patient is very important. So you must cater to the demands of the population you are screening. And there should be centralized registers for eligible people, and very, very important to have constant updates. So it's important that you have a buy-in from the healthcare professionals, the patients and the family. So it has to be a teamwork, and everybody has to be part of the screening program. It never can be that a hospital wants to do the screening. If the patient is not accepting it, then it's of no value. So accurate data collection is very important. Then only you can know what exactly are the prevalence in your local areas. And very, very important, you must cater to patients who do not attend and who are lost to follow up. Try to manage those patients because it's asymptomatic. So patients do not turn up. They don't see the need for it. So it's important that there are some challenges and barriers, that is decentralized healthcare or mainly private insurance-based healthcare have low success. Eligible population is basically increasing every year. The diabetes are increasing, so the budget also is a constraint to do DR screening. And majority of patients are asymptomatic, 90%. So in such cases, it's very difficult to convince a patient to get a screening done, even by the physician. Even they're not doing the screening. So that's also a major issue. So they know the patient is diabetic. Patient understands, but they don't get the basic checkups done. So less than 85% uptake of annual eye screening. So even once a year screening of a diabetic patient is uptake is less than 85%. That's a very, very high proportion of patients. So again, they don't attend DR screening programs, and just isolated DR screening without management of diabetes or having a specialist ophthalmologist providing services. So basically, you have to provide screening which also followed by management and patient engagement. So you have a complete cycle. So that is when you have success in this program, because patient maybe is lost to follow up even though he knows that he has diabetic retinopathy. So systematic telescreening is very important because it's cost effective. Patient doesn't have to travel all the way to a doctor. He can just be photographed. His retina can be photographed and sent to the doctor through cloud or other modalities. And targeted screening, including the private sector, is very, very important. Task shifting approach in India is required because there are lack of ophthalmologists in the rural areas. You'll find many of them that are there in the cities, but you will not find them in tier 3 areas or rural district levels where there's a need. So non-physician graders that are trained, and those are very important, like nurses, optometrists who are present in the rural areas, and they can take proper pictures and send it to the local ophthalmologists in the cities. So establishing screening pathways is very important, and quality measures, quality assurance and quality control is of utmost importance in having a good DR screening program. So the All India Society tells us that at least 80% sensitivity, 95% specificity and less than 5% technical failure rates is recommended in a DR screening program. So the ophthalmologist, the optometrist, the assistant, the eye technician, all must be certified graders when you're doing a screening program. It's also important in India, there's something called ASHA workers that are present at the rural community areas, the village areas. So they are incentivized, and if you incentivize them, they take care of the cataract screening program as well, because they go door to door, they make sure that the patients are screened, and they get incentive per patient that is sent and gets the surgery done. So same way, diabetic retinopathy can also be involved in such a way to track and monitor these patients through the ASHA workers. And monitoring of and evaluation of screening pathway is very important. Having constant feedback is also important. So the key steps would be identifying the eligible population, proper SOPs to avoid mis-screening, and referral threshold. So you should know when to refer, when not to refer, and what to advise the patient also. These are important things. So very, very important, as has been told by the previous speakers, is health education is the most important, because they can develop diabetes in later on, so they must know that they must get an annual checkup done. That's important. So, distributing flyers and other important animated videos are also very, very important through social media. And finally, it's important to build trust in the system so that the doctor and the patient have trust in each other for this program to be successful. So, very, very important to involve the private sector, because just the public partnership in India is not going to solve the uh, uh, problem with DR screening, because you require NGOs and you require private sector to be under the same roof so that you can do good monitoring and have a successful program. So that's all. Thank you so much. Thank you.
Thank you very much for a very, very illustrative. Any comments from you about diabetic? Are you doing any screening programs in South Africa for diabetic retinopathy? Please, Mike. Mike. In the meantime, I request Dr. Sahiban to please get ready for a talk. Yeah. Any screening programs you're doing for diabetic?
Yes, I think there are there's definitely some going around, but not enough. So I know, I think Shruti can maybe also comment in her area, but I know in Cape Town, yes, I mean, we are trying, but we are not, I think you mentioned 85%. I think we are less than less than that, to be honest.
What's your opinion? Yeah.
So I've worked in Cape Town and in the Western Cape and in Eastern Cape as well. So in the Eastern Cape, we're very, very under-resourced. So in our area, we're one hospital that serves basically the whole province. So we see everything. So by the time the patients come to us, they're already proliferating. They've got TRDs, they've got everything. So I mean, you actually don't have enough screening programs. So part of my research was also to implement screening programs into the communities, because we have private. So what happens in South Africa is you get primary healthcare, secondary healthcare, tertiary healthcare. But what often happens is that if you only got one ophthalmology department, everything comes to you. So you end up seeing everything. So there's no screening programs in our primary healthcare facilities. So we want to roll out some fundus cameras at least to the primary healthcare facilities, and usually I'd ideally want to use AI-based technology, so that at least we have something, so that we can at least get some diagnosis, that they can get the serial tests every year. But it's very under-resourced.
I think you should think of teleophthalmology, because that way the load on the hospital and the one ophthalmologist in that hospital would be really reduced, because tearing, itching, redness, all that will be just segregated. You can take care of that on teleophthalmology. Only serious cases can come in. I think that would be a good idea.
So the problem is also funding.
Yeah.
I mean, funding is an issue. So I mean, so if we do one PPV, essentially, we'd say 50,000 rand, which is times that by 5 for rupees. So it's expensive, even for the government sector. It's expensive.
Yeah.
Whereas, if we get a fundus camera, that's 200,000 rand times that by 5 as well for rupees. So if you do four PPVs, that equates to getting one fundus camera, which serves a massive population. So that's what we're aiming to roll out at least. And then I don't know, what do you think of things like Remedio, or with the AI-based technology? So at least it helps, because otherwise you're putting the burden back onto the ophthalmologists. Because you need them to
interpret.
Exactly.
Yeah.
I don't know, what has your experience been with that?
So I'd like your opinion about this also before.
So I've worked in rural KZN, and I don't know if you know Gray's Hospital, but Gray's Hospital is a tertiary hospital, and it services Northdale, Edendale, and Church of Scotland. So those are a whole lot of periphery areas. So I used to be in charge of getting all the referrals coming through to me, and I would do a lot of screening through that way, sort and send type of thing. So it was really good, because that was a tertiary center, and those were all the ground workers, and then primary, and then secondary. So it was very stratified, I would say, in northern KZN. Now that I've come back to southern KZN, I'm not really involved so much, because that was a government incentive, but now I'm in private practice. But I do clinics for other things back in McCord's Hospital. I don't know if you're familiar with that, but that is the government eye hospital that's present there. Now they have a lot of these kind of caseworkers that actually go out and take photos. And there was recently I think a thesis on AI in ophthalmology, trying to set up a program for this type of thing. So it is starting, but we've got so many other problems that this is sort of to the wayside in KZN, I would say. Yeah. Thank you.
Thank you very much. We now request Dr. Saiban Sethi, glaucoma consultant. She did her her studies at the Ramchandra Medical College in Chennai, and then a fellowship at the Shankar Netralaya, the prestigious one in Chennai, and specialized in glaucoma there. And she also happens to be Dr. Aditya's wife, and they both met at Shankar Netralaya, so they had an eye-to-eye program.
Thank you so much, and I'm honored to be here. So today we're here gathered talking about volunteer eye surgeons. So I'm going to be talking about something that I volunteer to do because it's very close to my heart. And in Arunodaya, we feel the only way to actually get into the system when it comes to a disease which is completely silent, which is completely asymptomatic, is to get to the community and tackle it at the root. So I'm going to be taking you through what we believe and what we do when it comes to outreaching patients in terms of glaucoma at Arunodaya. Now, why are we talking about glaucoma in the first place? That's because 12 million people in India are living with glaucoma, out of which 6 million are blind. So this is the statistic as of today, and it is only going to double by 2040. And 50 to 80%, and this is a whopping statistic, of these patients are undiagnosed or untreated. So you can understand the magnitude or the burden of glaucoma that we are suffering with in India. So we at Arunodaya, we feel that we should give before they give up, because honestly speaking, you're reaching out to people voluntarily who don't even think or know that they need help. So that's a very difficult barrier to break. So we are a non-profit organization committed to the cause since 2004, and glaucoma has been one of our main focus. So we, time to time, have various community-based glaucoma awareness strategies. We have outreach camps to screen glaucoma in the community. We identify the high-risk glaucoma suspects. Another challenge with screening glaucoma is that any 1 in 6 people can have glaucoma. So how do you really go out and screen the entire community? So I think the better way of doing it is you identify high-risk population, whether it's old age, whether it's people who are on steroid therapy, people who have family history. So there has to be targeted screening for any of these outreach camps to actually be efficient and be cost-effective. All the identified glaucoma patients are then referred back to the base hospital for further evaluation, and medication or surgery is instituted as and when required. So far we have executed about 3,980 camps successfully, out of which 1,19,400 patients have been screened. Multiple patients have been treated at the base hospital, many of them out of which have also undergone glaucoma procedures. So this is a very simple basic methodology we follow to just make it a little more, let's say, organized and more time and cost effective. Initially, a registration is done, following which visual acuity is checked for all patients. A very cursory slit lamp examination using the handheld slit lamp that you can see is done. And also we have two methods with which we measure the intraocular pressure. One is the non-contact tonometry. This is again another make-believe structure, because non-contact tonometry is let's say pretty much a non-portable machine, but this is one of the ways that we can actually utilize it in camps also, so that there is no time lost in patients sitting and rearranging their heads. You can just have a standee over there. Rebound tonometry, of course, is way more convenient. And all the patients who need further evaluation or treatment are taken in our mobile vans back to our base hospital. Dilated checkup is done only if indicated at the camp level, which is rare. So this is our fully equipped mobile van. which has all the equipment. We have a slit lamp. We can do refraction here. We can do automated keratometry. We can do automated refraction. Even the IOP, the NCT is mounted over here. And this is the van which is also utilized to take the patients back if required. From time to time, we also have glaucoma awareness talks, skits, movie screenings, radio shows. Incidentally, this is also the World Glaucoma Week that we are observing from the 11th of March to the 16th of March. And we've done various campaigns, we've done various exhibitions, shows out there to just sensitize, to at least get people to talk about glaucoma, to be curious about glaucoma so that they can go home and learn about it, or maybe talk to other people in the community to just spread and create awareness about such a condition that exists. So these are some clips from what we have done in World Glaucoma Week 2024 before coming here. So we have held multiple camps at multiple places. A lot of these patients have been screened at our base hospital as well, and whoever requires undergoes surgery or medications. I think what also sets us apart is that all the patients who are identified or screened for glaucoma, they also become our ambassadors or sight savers to spread awareness. So good education about what their condition means, what implications it has to their future, and how it can affect their family members, and also by and large humanitarianly to other people in the community is very important. So if you teach one teaches 10, those 10 people teach 100 more. So this is how, we propagate awareness about glaucoma in the community. And our directors are right here, and they are spearheaders of these projects, and they very, very deeply believe in community work, and I'm proud to be a part of the association. Thank you.
Thank you very much, Dr. Saiba, for a lovely presentation and awareness on how glaucoma actually is a Scrooge. If 50% of the patients are already blind, this is a catastrophe. It's actually a catastrophe which people should be made aware of. And unfortunately, diabetes and glaucoma, they don't take very seriously, because it's a lifelong thing they have to treat. So if there are any questions, otherwise, two of our speakers have, I think, one has gone to North India. Dr. Schultz is not here. And who's Dr. Amar Pujari? Does anyone, Have you got his number? Just give a ring. Is he coming? So I think he's probably busy elsewhere. So we are going to gather now for the National Symposium, which is going to start at 11 o'clock. So you have 15 minutes for coffee. And as you know, two of you are on the panel if you see the book. And you'll be asked questions on your systems of management in South Africa. So please brush them up. And we look forward. So before that, let's have a group photograph. And thank you very much, Dr. Saiba. And tomorrow onwards, you'll be hosting the doctors at Arunodaya. They also need to do some sightseeing, and then they want to go Ahmedabad. Yeah. So from Agra, we'll send it to Udaipur, and Udaipur, because that's the route you take. So you just drive along. And in Ahmedabad, we are very good friends of an eye hospital. You can visit them also.